All right, let's talk about brachytherapy. It's this really powerful and honestly super precise technique in the fight against cancer, where we flip the script and deliver radiation from the inside out. So let's just break down exactly what we're talking about. The name itself, brachytherapy, actually gives you a huge clue. It comes from the Greek word brachy, which means short distance. And that's the core concept right there. It's a type of radiotherapy where we put tiny radioactive sources directly inside or right next to a tumor. This lets us deliver a really high dose of radiation and do it safely.
Now, you might think this is a brand new idea, but it's not. This technique has an incredible history, starting way back in 1901, literally right after the Curies discovered radioactivity. And get this, by 1903 it was already being used to treat cervical cancer. From those really early pioneering days, it's grown into an absolute cornerstone of modern cancer care.
Okay, here's how we're going to tackle this. First, we'll nail down the core principle of brachytherapy. Then, we'll look at the toolkit, the nuts and bolts. After that, we'll get into the planning process, see how it's used in the clinic every day, and wrap up with the key risks and why teamwork is so critical.
So let's really dig into the fundamental advantage of this whole short-distance approach. What makes it so special? Okay, here's the magic. By putting the radiation source right at the target, we can hit the cancer cells with a much higher, much more powerful dose. And because it's so close, that radiation dose falls off really fast. This means we can spare all the surrounding healthy organs from getting blasted with unnecessary radiation. It's a total game of precision. All right, let's move on to the tools of the trade. How do we actually deliver this? You know, the toolkit for brachytherapy is incredibly sophisticated and really specialized.
So, one of the first things you've got to wrap your head around is the dose rate. We basically split brachytherapy into two main types. First, there's low dose rate, or LDR. Think of it as a slow and steady approach, a continuous dose over hours or even days, which usually means a hospital stay. Then you have high dose rate, or HDR. This is the complete opposite. Powerful, short bursts of radiation over just a few minutes. This can often be done as an outpatient procedure.
Now, the choice of radioactive isotope is a huge deal, and it's always tailored to the treatment. As you can see here, Iridium-192 is really the workhorse for almost all HDR treatments. But for LDR, especially for things like permanent prostate seed implants, you'll see isotopes like iodine-125 or palladium-103 used all the time. But wait, how do we get these little tiny radioactive sources exactly where they need to be? Well, that's where applicators come into play. These are the specialized instruments that guide the sources right to the target. And this is where it gets really cool, because it just shows you how adaptable brachytherapy is. There's a whole lineup of applicators, each one engineered for a different part of the body. For GYN cancers, we've got things like vaginal cylinders or a tandem and ring. For breast cancer, there are these balloon-like devices. Mammocyte is a common one. For eye tumors, we have plaques that are literally sutured onto the eyeball. And for lots of sites like the prostate, we use these special interstitial needles to place the sources directly into the tissue. Now, it's not just the hardware that's evolved. The evolution of treatment planning is just as remarkable. We've gone from these elegant but kind of rigid rule-based systems to highly personalized, image-guided precision. It's been a total revolution. Think about it. Back in the day, planning was all based on these empirical systems, like the Manchester or Paris systems. These were basically rule books, using idealized geometries to try and get a predictable dose. You know, they wanted to make sure the dose was spread out evenly. They were really clever for their time, but they just didn't have that patient-specific detail we need.
Fast forward to today, and it's a completely different world. Now we use advanced imaging to create a super precise 3D blueprint for every single patient. With CT-based planning, we can see the dose distribution in real time. MRI gives us this incredible soft tissue detail, which is just invaluable for GYN cases. And for prostate brachytherapy, transrectal ultrasound is the gold standard for real-time planning and guiding the needles.
Okay, so we've got the theory, we've got the tools. Let's see how this all comes together in the clinic. Where is brachytherapy making the biggest impact today?
First up, cervical cancer. And I want to be really clear here. For locally advanced disease, brachytherapy isn't just another option. It's an absolutely essential, non-negotiable part of a curative treatment. We typically use it as a boost right after external beam radiation.
And the outcomes? Well, they speak for themselves. With modern image-guided techniques, recent studies show a 5-year local control rate of up to 98% for early-stage disease, I mean, just think about that. That is an absolutely outstanding result.
Okay, next up, let's talk about prostate cancer. This is another area where brachytherapy offers just excellent outcomes for patients all across the board, from low risk all the way to high risk disease.
It's just so versatile here. For guys with low-risk disease, it can be the one and only treatment, what we call monotherapy. For higher-risk disease, it works as a powerful boost along with external beam radiation. And the results are incredibly robust. With biochemical control rates, that's controlling the PSA levels, somewhere between 85 and 97% at 5 years.
Brachytherapy also provides a fantastic option for certain patients with early-stage breast cancer. It can offer a much more convenient and way shorter course of radiation after they've had a lumpectomy.
So this technique is called accelerated partial breast irradiation, or APBI, and this is a huge deal for patients. Instead of coming in every day for 6 weeks for external radiation, a patient can be done with their entire radiation course in about 5 days, getting treatment twice a day. And the most important part, long-term studies show the local control rates are just as good as the longer traditional methods.
Okay, let's wrap up with some really important points. No procedure is without risks, and success just doesn't happen in a vacuum. We need to talk about patient safety and why care coordination is everything. Counseling patients properly is absolutely vital. We have to be upfront that this is an invasive procedure. We also know that things like smoking can make side effects worse and even make the treatment less effective. And this is a big one. Outcomes are hugely dependent on the skill and experience of the physician and their entire team.
And that brings me to this crucial point. Brachytherapy is not a solo sport. It demands a super tightly coordinated interprofessional team. We're talking about the radiation oncologist, the medical physicist, the dosimetrist, the nursing staff, radiologists, anesthesiologists, everybody working together perfectly to make sure the treatment is safe and effective.
So when you look at the whole story, from its earliest days to today's incredible image-guided precision, brachytherapy is just this dynamic and powerful force in oncology. And it leaves us with this exciting question to think about. As our technology for imaging, planning, and delivery gets even better, how is this incredibly targeted, short-distance therapy going to continue to reshape the future of how we treat cancer?